Welcome to the CareCentrix AHIP video series. Today I'm joined by Bruce Greenstein from LHC Group. We're here this morning to talk about some really interesting aspects of home health care. And we're going to begin with introductions. Bruce and I will share our backgrounds and then talk through some questions related to how to increase access and the efficacy of home health care services for patients coming home from the hospital. My name is Dr. Mike Cantor. I'm the Chief Medical Officer for CareCentrix. I'm a geriatrician and a lawyer by background. And it's my pleasure to work for an organization where our mission and our vision is to provide more care at home, really to see a world where anyone can age or heal at home. And so we believe very strongly in CareCentrix at bringing the care to the patient rather than bringing the patient to the care. And so the questions related to how to improve care at home for older adults and for anyone who actually needs those services are critically important for all of us as our society continues to age and the needs of people continue to grow and evolve. Here with me is Bruce Greenstein. Bruce, do you want to say a bit about your background?
Sure. Well, thanks for having me to start with. Bruce Greenstein, I'm the Chief Strategy and Innovation Officer at LHC Group. It's one of the nation's largest, we'll say, post-acute care or home care company. And we do a few things. We do traditional home health. We have a hospice portion of the business. We do, for mostly Medicaid services, personal care. And we have one of the largest ACOs in the country. And when we roll it up, we tend to think about what we do as post-acute care data science as well, as a different way of thinking about how we approach what we do. I'm a health economist as a background, and I've spent about half of my career in the public sector, both in state and federal government, and about half of my time in the private sector, and about that's been split between technology and on the provider side. So I feel like coming to the post-acute care space is the opportunity to iron out massive amount of what we see as variation and lumpiness across post-acute care in the country, and bring some order to that part of the American healthcare system to provide better outcomes for patients, better experience for families, and better value for payers. And that's how we approach everything that we're doing in the home today.
Great. One of the challenges within home health is that, our health system at large, is that rather than being a nicely integrated system where people talk to each other and patients expect that when they see different doctors or they get different services, that those doctors have talked to each other, that the people in the hospital have spoken with the folks working in home health. Unfortunately, that's not always the case. Can you say a bit more about some of the challenges we face in terms of the disorganization and sort of the lack of continuity between care settings, and your thoughts on maybe how to fix some of those gaps?
Yeah, you set it up really well because it is not organized and it's not integrated, but it doesn't mean it's disorganized and disintegrated. It just means it lacks those states of being. And there's some reasons why. So let's talk about it. Even in circumstances where a big integrated delivery system that may be enlightened of putting their patients in some kind of clinical workflow with integrated technology end to end really comes to the water's edge when it comes to the home. And it's not home health specifically, but health systems have a hard time taking their patient from their vast amount of, seems like a chaotic world within the hospital, but data tends to follow the patient, lab results follow the patient, and there are ways that the patient gets taken care of. Those orders at the end of the, say, episode or stay, those orders to go home or just to leave the hospital are part of the system, but once they leave, it's really over. The data doesn't flow back in an automatic way. The relationships tend to be by fax and phone instead of in one integrated system. And it's not organized, as you mentioned, and that's because usually the risk, the financial risk, lies outside of the system. You have another group of people that are looking over the costs associated with that are not part of where the patient came from. And even the quarterback in the whole game, which is usually the primary care physician, the primary care physician becomes 2 steps removed if they were 1 step when the patient goes to the hospital, and then 2 steps now when they come home, even though they should be the driving force. And so that in itself creates opportunities to more fully integrate care, and health systems around the country today continue to express their interest in making the home just another part of their health system, just in a more distributed way. And for payers, it is the opportunity where we spend a lot of money in post-acute care, We don't track it the way we do in other parts of the healthcare system, and we tend to look to contract it as if it were a commoditized service, like we would do, say, for a set of diagnostic labs. And in this case, it is as strategic a piece of managing the patient's overall cost of care and overall clinical outcomes as any other part of the healthcare system.
Makes sense. What do you think we should do to make that better? How do we break down some of those gaps and the different incentives that the different components of an integrated delivery system or private practice, primary care doctor, home health agency, hospice, skilled nursing facility, how do you bring those pieces together?
So let's talk about what's going on right now, because I think our entire healthcare system is pointed in the right direction. We're oriented to the right incentives, and we're beginning to make progress. The conclusion of that is we're not making nearly enough progress and we have a long way to go. So that's the punchline. But the lead up to it is, if you look at in the Medicare program, the development of the ACO program within CMMI, the Centers for Medicare and Medicaid Innovation, there's a lot of experimentation going on that brings to the primary care world the oversight of all the care that's being consumed. And as one of the largest providers of home health, we work with ACOs all around the country. And for the most part, it's been about how you rationalize the amount of care that goes on. Not too much home health, not too many recertifications for certain patients. So there's been a recognition that, oh, home health costs something, we need to have oversight. What it misses almost entirely, and this is a big opportunity, is to look at all of post-acute care and say, how can we have the best, most efficient approach to get the best clinical outcomes, but also have the lowest costs associated. So I'll go a little bit deeper here. If you look at data from the last several years in Medicare, of all of the post-acute care that gets delivered, about 40% of hospital discharges end up with some post-acute care. So 60% get no post-acute to start with, and we'll talk about them in a second. Of that amount, 90% of all post-acute goes to either skilled nursing facilities or home health. And of that, the breakdown is 61% go to a skilled nursing facility and 39% go home. Now, we know from various studies that a very large portion of all those that go to the skilled nursing facility are clinically appropriate to be treated at home. So why aren't they? Well, there's usually a lot of disruption in families' lives. Patient may have gone to the hospital through a 911 call. There may not be family members around. I'll tell a quick story to illustrate this. I had a friend who was, her husband was having a knee replaced, and the gentleman was in the hospital. And the wife, a friend of mine, who's a nurse, was with her husband, and it was in Massachusetts, sort of an old school hospital where they have two patients in the room still. And the other patient in the room had the same exact surgery and had the same disposition. And my friend's husband was getting ready to come home. And my friend asked the other patient, so when are you going home? And he said, no, I'm going to a skilled rehab facility. She said, how come? And his answer was, my wife died 2 years ago. Nothing clinical, it's just a circumstance in the home. And so we use a very expensive medical institutional treatment to overcome what are social issues, social factors to overcome. And so we see the over-medicalization and utilization of some of the most expensive elements within post-acute care to make up for what we could otherwise do if we had the ability to make our benefit package, to make the benefit itself, to bring healthcare at home to be more fulsome. And I think we'll probably talk about that at some point today.
Yes, it's interesting you mentioned that particular case. There actually is a study that shows that knee replacement patients who live alone do just as well with home health care as they do with skilled nursing facilities, despite the lack of having someone,
right,
literally at hand. And so it's just that old style belief that unless you're going to a place with nurses 24/7, and we all know how busy the nurses are in a skilled nursing facility, by the way,
right,
that you're not going to be able to survive or do well. And that's just, the data indicate otherwise, and your experience and my experience clearly indicate otherwise as well. One of the challenges, though, is when you think about it, you've got the hospitals and the physicians. Their goals are slightly different than the skilled nursing facilities, who get paid based on how many days that person stays in that bed, which is different than the home health agencies, or who are thinking, how many visits can I make, or how many visits can I avoid, depending on how you're getting paid, which is another challenge I would imagine in terms of how you run your organization. But how do you think we can literally get everyone on the same page so we don't have doctors motivated one way, skilled nursing facilities a different way, home health a third way, and the poor patients and their families kind of wondering, so why did that patient have to go to a skilled nursing facility?
Right.
Why didn't the doctor say, hey, we can actually send nurses into your home health aides into your home, we can call you every day, we can have video conferences, we can do lots of things today to make sure that you're fine, and if there's a problem, we'll have you come back into the skilled nursing facility and we can take care of you there. How do we do that?
Yeah, so again, this is another area that I think our healthcare system is making progress. There's a concept, and we're here at AHIP, which is, really it's the premier conference around the payer space. And we've watched in the news over the last several years consolidation occurring in the payer space. While that consolidation is happening, we've been observing the decentralization of risk. So there may be fewer payers overall today, but the risk from those large payers are being distributed to the provider side. And I think this is very healthy. We work at LHC, we work with over 75 joint venture health systems, make up about 355 hospitals, and many of those health systems are taking full capitation risk from MA plans. So two large systems that we work very closely with, one is Ochsner, they have about 35,000 full cap risk patients from Humana, and in Dallas, THR, Texas Health Resources, has about 71,000 full cap risk patients from United. Once the provider gets the patients and then owns the risk for those patients, they start to make more active decisions about how best to serve those patients from within their system. And in this case, those two health systems have recognized that home health is too important to make it just kind of a side issue that the hospital looks at but doesn't spend enough time on. And they're quite aware that they needed to have something that was best in class to complement what they are best in class of for the rest of their health system. So once we start to look at that, then we can make these decisions about how to help discharge planning and case management, how we can help educate parents, how we can help educate the primary care physician or the hospitalist that's making recommendations. And so once you start to move up that chain and you get financial incentives aligned, you have organizational incentives aligned, and then you make the decision primarily up to the patient and the physician, you get much better outcomes. But when it doesn't seem like there's an opportunity to really go where you want to go and get what you want to get, you end up getting seemingly the most expensive care, and you tend to stay for a long time. In 2016, the average length of stay for Medicare was 27.07 days. That's an awful long time for post-acute.
In a skilled nursing facility?
Yes. We know we could do one, bring down the percentage of people that end up going to a SNF that want to go home, and two is shorten that length of stay and bring people home faster out of the SNF.
I've heard some of the skilled nursing facility industry begin to push back as the pressure mounts on them to cut their length of stay, to cut the percentage of patients that are admitted there. They say that it's much safer to put someone in a skilled nursing facility than to send them home, despite the data that you and I have just talked about. And I think it's not helpful to have a war between the skilled nursing facilities and the home health agencies over who gets the patients after discharge. What are you doing to help kind of bridge that gap and create the alignment? And do you see the skilled nursing facilities as competitors, collaborators? How are you addressing this sort of growing schism, I would say, between the two parts of the post-acute care system?
I don't know that it's a growing feeling of friction. I think it's been there all along, but now from the payer side, there is more friction to the SNF. And if I were running SNFs, part of the reason why you have such long lengths of stay is that the payment rates are quite low. And so if you have a high needs patient that comes in, you're likely losing money on that patient for X number of days. And so you need a financial time horizon to be able to recoup your losses from the beginning of the episode and make sure that patient is really ready to go home without having to be readmitted to the hospital. So the question there becomes, How do you select the patients that really need to go to the skilled nursing facility and are, say, too acute or clinically not appropriate to go home? And I think that's really where the sorting out can take place. I would like to see lengths of stay be perfectly appropriate in the SNF because they're not clinically appropriate to go home, not just because it's more convenient or it's because of a improper financial arrangement that has to take a long period of time to make sense. I would be looking to contract to have appropriate rates from the first day and then keep those lengths of stay to appropriate levels. Now, to get to your question though, we operate LTACs around the country, and we have management agreements to run SNFs, so we are part of the facility-based operations. And what we tend to see is, especially with our hospital JV partners, the SNF is such an integral part of the overall delivery system, and we find that SNFs tend to get backed up, and then the hospitals have a hard time discharging their patients when they're ready to go to the SNF because people are in the SNF for too long. So it becomes, in that world where there's excess demand on the facility-based post-acute solutions, it becomes much more virtuous if you're able to flow your patients through more quickly and bring them home when appropriate, instead of locking people up and thinking about them as a revenue opportunity rather than a patient that really has to get the most appropriate care.
So other than ownership and having a stake, foot in both camps in terms of facility-based rehab and home health, home-based rehab, how do you see creating alignment between those different provider organizations? Because as we started out, there's this sort of fragmentation today across the system. Other than having sort of co-ownership, and the insights that you have because of that may not be shared on either side in terms of what the challenges are for home health from a SNF perspective or SNFs from a home health perspective, how do you think we can move as a healthcare ecosystem to become more connected and to appreciate the strengths and the opportunities that exist in the different settings?
Yeah, I think that all providers have to dispose of the idea that they have an entitlement to patients, and instead there is only the ability to earn patients. So creating high-performing networks that are about high quality of care and the clinical outcomes that emanate from it, as well as the efficiency of cost. Not every home health company is 5 stars and produces high quality care, and they don't deserve to get patients just because they're a provider. And the same goes with skilled nursing facilities. If you look at CMS stars data, it's really quite distributed. We don't see all of the facilities just all clustered around 4 or 5 stars. They're actually distributed across. Well, further, what we found is that many of the skilled nursing facilities with poor star ratings tend to be the ones that charge the most. They tend to do the most therapies. Their total cost of care is quite high. So if I were organizing the system for my patients, especially if I'm taking financial risk, I would be very selective about working with the highest quality care providers and assure that there is some kind of value-based arrangement that rewards those providers for doing exemplary work in efficient ways. And we're now in many arrangements like that, and it tends to start to change the culture of the provider world so that you're able to count on additional dollars coming in to then provide care that you're not otherwise being compensated for. And you end up spiraling up. You have happier patients, they have better outcomes, you save more money in the long run, and the providers tend to be happier to be able to do more about the patient and what they're trained to do.
Great, so in other words, if we had a system based on quality, where the flow of patients depended on your providing the best service and outcomes, and by the way, our data sets show there's very little correlation between the stars ratings and the actual quality in terms of readmission rate, cost per stay, length of stay for skilled nursing facilities. So we still need to work, I think, on some of the metrics and the measurement challenges for home health as well as for skilled nursing. But if we paid based on quality and we paid people more for higher quality and we sent more patients to higher quality facilities, and in turn to higher quality home health who also get incentivized financially providing that care, if everyone were sort of motivated towards the same quality goals in addition to financial goals, perhaps that's a way to bring people together. Is that right?
I think so, and the quality measures are meant to bring about 2 different type of outcomes. One is so that patients and families can choose a high quality provider, and the quality, of course, is organized in the minds of people at CMS. that believe that this is what represents quality, and then we all skate to the puck wherever that puck is going. But the other side, it should be for those that are in the payer space to know who best to contract. And that becomes a little bit trickier. Everyone should have their own internal metrics to be able to do their purchasing. But in this case, we rely on CMS's measures to some degree, and then as that gets more mature and really represents some combination of clinical quality and outcomes as well as financial performance, then it'd be a lot easier to contract for the best outcomes for everyone.
Got it. Now, one of the challenges is that because of the lack of integration, the lack of shared incentives, the lack of meaningful quality measurement, that with the financial support for that, new organizations have begun to emerge and to take their place in improving the quality of post-acute care. CareCentrix is actually one of those organizations. For example, we look at and we use data-driven tools to figure out not just what is a high-quality skilled nursing facility or home health agency, but what's the best for this particular patient. Because some SNFs are really good at cardiology and take care of cardiac patients after acute heart attack very well, others are better at orthopedics. We have data systems allow us to crunch through the experience of millions of patients to figure out, for patients like this, what's the best place for them. Joining us in this sort of new world of outside people coming to work with home health agencies, skilled nursing facilities, are others who don't really fit in terms of the traditional models of managing post-acute care or chronic care in the home. And it's interesting because we don't really have that sort of set categorization, like, oh, when I tell people what I do, they're like, so what is that? They don't really understand kind of, we manage post-acute care, we work with home health agencies and with facilities, we use data to drive the best results, we do it on behalf of payers. That's a different model. We've had to game the system in some ways. What's your thought on these new entrants? There are a bunch of other companies that are in a similar space, and how we're sort of being forced to kind of, fit a square, round peg in a square hole.
So that's a great question. Both CMS and the Medicare program are these very large institutions that have grown up over time and they're relatively rigid. We don't make a lot of changes to them quickly, but we tend to add new benefits over time and maybe tweak the payment methodology. So when you think about where the innovation is really coming from, there's some that's also from the federal government through the innovation arm, but so much of it is coming through working with Medicare Advantage plans and then new companies that come basically to trick the system. We basically say, let's focus on what tends to be the most difficult patients or the most expensive patients. They're oftentimes the same. And what can we do to put together a customized care package and a new delivery system for them that really focuses on what their issues are, what's causing the greatest amount of spend, and manage it and rationalize it. And so companies that have come up like CareMore and Landmark and Aspire all look at different type of patient modalities, but they all spend a lot, and their programs tend to focus on ways to care for that patient in a better way. It happens to be that most of the innovation comes with bringing a lot of care into the home. So we're basically saying that we have very good mechanisms set up to pay for expensive care in large buildings with a lot of people working there, very expensive institutions. And instead we're seeing companies use innovation as a way to bring patients to the home, to use technology, to use different type of professionals in the home to accomplish what's often better quality care and better outcomes for both the patient on clinical outcomes as well as financial outcomes. So I expect to see more of it. Your question about how do you explain what you do as a job, to some degree, it's a lot like going to buy a house. Oftentimes it's the largest investment a family will make, and it's hard to imagine going through that process without having a real estate agent and somebody in the bank helping you out. And so they end up getting you the best deal, and they get to learn, maybe not quite as scientific as your methodology is, but they get to learn what your interests are, what your likes and dislikes from home, and then they go ahead and execute the best financial arrangement possible for you. And to some degree, I look at what you all have been doing in this world where there's not a lot of good data. There is a lot of commoditization. It's a very distributed world. There's not, say, 3 or 4 brand names that go across the country that make up 75% of market share. Instead, there are 4 or 5 big companies that altogether we make up 21% market share. So that means there's almost 80% that are regional and small mom and pop providers. So you have to make sense of this very distributed, very lumpy landscape, and it's difficult, but I think we're in what will be known perhaps in years from now as the golden age of post-acute care, because the appetite for rationalizing it has finally come. The ability to do it with financial contracting as well as high quality providers are finally here. And also we have people in Washington, D.C. that are looking at post-acute care to figure out what to do. There are some in CMS that are looking to put a bundle together around post-acute care. I'm on work groups to put together post-acute care interoperability. So from a data perspective, we can follow patients across the whole care continuum. And we're also looking at ways to apply AI. This is another CMS-sponsored activity. How to apply AI to making the best decision on where patients go in the post-acute continuum. So I think there's enough interest there, and I think that what you do with your company will be an indicator if this is going to be successful moving forward in the next 10 years, or it will just be another expression of utilization management or price arbitrage, and we haven't gotten very far by just doing that.
Agreed. We focus on clinical management, rather than utilization management, because we recognize the complexity and the challenges of patients and that immediate discharge time after they come out of the hospital. And Bruce, thank you so much for your comments, very thoughtful insights. Really appreciate your time and look forward to continuing to have a dialogue as we both our organizations and both personally work to continue to improve the quality of care and the health of patients that are entrusted to us after they leave the hospital.
Thank you for the opportunity.
My pleasure. Thank you for joining us. This has been the CareCentrix AHIP Video Series Part 2.